Hello and welcome everyone. This is Caleb from Task at the National Rural Health Resource Center. This is the breakout room 1B for titled Transitioning to Value-Based Models with Flex Program Support. This is day one of the 2020 Flex Program Reverse Site visit. I've got a couple of housekeeping items. So we are in a breakout room here. So if you have issues, technical difficulties, please utilize the chat feature and we will get you technical support from there. Down along the bottom of your screen, you can see the chat feature. You should be joined to the room muted by default. If you have a question, there will be time for questions during the end of the webinar or the presentation. So please hold some questions till the end, as we'll end up with additional background noise. Following this session, we'll have a 10-minute break, after which we will reconvene at 1:20 for a facilitated discussion focused on COVID-19. At the conclusion of that breakout session, there will be clickable links to small group discussion on the screen. A reminder that all sessions are being recorded and we will provide the recording as soon as possible. I believe that is most of my housekeeping items. I want to introduce Stephanie and Jen. Stephanie Sayeg is from the Idaho Flex program, where she's been since 2011. She's the Flex and Ship program manager and provides technical assistance to the 27 Idaho critical access hospitals. She's native to Idaho and has spent many years working abroad. Jen Edwards from Pennsylvania Flex program, as well as the SHIP program manager in Pennsylvania, has been working with rural healthcare organizations or healthcare organizations from clinics to medical centers in a wide variety of positions for over 15 years. And they're here to talk to us a little bit today about their efforts within their state and how their Flex programs support that. Focused on the transition to value. So Jen, if you're ready, I will mute my microphone.
Sounds good. Thanks. Good afternoon, everyone. I am going to talk for a little while about Pennsylvania's transition to value-based care and how the Flex program, how we've utilized the Flex program to support that transition. So I'm going to talk a little bit about the development of the Pennsylvania Rural Health Model, and then the overview of global budget structure and how it's different than Maryland, strategies to reduce potentially avoidable utilization, and then Pennsylvania's rural health model focused flex activities and the progress on those, also the challenges that we have had, and successes and best practices, and then other considerations that we have used in moving to value-based care. So Pennsylvania actually started the process to move towards implementation of the rural health model about 8 years ago. Pennsylvania applied for and received 2 CMS state innovation model grants. The first one was for planning and the second one for testing. And this was at a time when Maryland was rolling out their global budget model, which eventually it became mandatory for all providers in Maryland to participate. So at this time, Karen Murphy was the director of the Centers for Medicare and Medicaid Innovation. And Pennsylvania actually recruited her to become the Secretary of Health for Pennsylvania. And she started in that role in May 2015. And that was after the time that Pennsylvania had applied for and received their state innovation model grants for planning and testing. So when she became when Karen Murphy became the Secretary of Health, one of her primary goals was to transform Pennsylvania healthcare and include rural health in that. So she and a team of partners, which also included the Pennsylvania Office of Rural Health, created a proposal for the Pennsylvania Rural Health Model. And it was ultimately approved by CMMI in 2017. So it is the first model to be focused on rural health. So the Pennsylvania Rural Health Model is an alternative payment model, and it's designed to address financial challenges faced by rural hospitals in Pennsylvania by transitioning them from fee-for-service to global budgets. This provides stable monthly payments from participating payers and allows hospitals to focus on delivering value-based care and transforming the care they deliver to better meet the community health needs. So, as I mentioned, Pennsylvania's first state in the country to design and implement a model such as this that's focused entirely on rural. And there was a delay. Pennsylvania was not quite ready to implement in 2018, even though it was approved in 2017. So there was a year delay. So the first year of the Pennsylvania Rural Health Model started on January 1st, 2019, with 5 hospitals and 5 payers that were participating in year 1. Currently, we are in year 2, and there's 13 participating hospitals and 6 payers. So I want to, before I go into the slides that are actually the Department of Health and CMMI slides that they use to present the model, I'm going to talk a little bit about the administration of the model. It is currently transitioning out of the Department of Health into the Rural Health Redesign Center. So back in November of 2019, the Pennsylvania legislature passed legislation, Senate Bill 314, which was signed into law on November 27, 2019. And it was to create the Rural Health Redesign Center. And this was a separate entity outside of the Department of Health to focus on recruiting and implementation for the Pennsylvania Rural Health Model. So they had 180 days to create the entity, and that entity has been created, and there is a board established, and it has been meeting. So they are beginning to take over and work through that process. So before I talk about the PA Rural Health Model in detail, I just want to talk about several key differences between the Maryland model and the PA Rural Health Model. So the key driver of the model was to retain access to care, to high quality care, and to keep jobs in the rural areas, versus Maryland, their key reason was cost containment. Now, obviously, we do want to contain costs, but that was not the key driver of the model. Also, there is no global rate setting functions in Pennsylvania like there is in Maryland. Maryland set the global rates, and then all payers had to abide by those rates. Each hospital has their own negotiated rates and contracts with each one of these payers. So that doesn't change just because of the model. And then also there is no all claims database in Pennsylvania. So it's a little more difficult for the information to get. So that is something that has been a little trickier here in Pennsylvania. Okay, so if you look at this map, this shows all the rural hospitals across the state, and the dots represent their 2018 total margins. This data was actually extracted by the Pennsylvania Cost Containment Council, and as you can see, there are a lot more red and yellow dots than there are green. So the goal of the model, as I said, is to prevent rural hospitals from closing. This keeps the access to high quality care local and prevents an economic crisis in the community if the hospital were to close. Okay. So the model provides protection from some challenging issues that are facing rural healthcare. So when you look on the fee-for-service side, volume fluctuations is definitely a risk. But the model has a predictable revenue stream that is independent of current volumes. In the fee-for-service side, if you have provider resignations or recruitment challenges, this can be a huge impact on revenue. But because of the way that the model is designed, this protects hospital revenue, and you do not feel the immediate impact of provider departure because it's based on prior year's revenue. Competition with tertiary centers for volume. It's no longer a driver under the model. The model enables service line analysis and optimization, which aids in bringing appropriate utilization back to the community. Fee-for-service investments in population health tend to be the right thing for the community, but it's the wrong thing for the bottom line. Under the model, this eliminates that concern because you're paid to keep people well, essentially, through a reduction in potentially avoidable utilization, PAU. Hospitals that reduce unnecessary emergency department visits and hospital readmissions keep those funds and reinvest in population health initiatives. And then also under fee-for-service risk, regulatory barriers prohibit innovation, but within the model, opportunities exist to apply for waivers of regulations that may stifle innovation. So these include potential waivers to national and state policies and regulations that may present barriers to an organization's transformation plan. So there's two core tenets of the model. The first is the model stabilizes cash flow from all the participant providers. So hospitals receive equal monthly payouts every month once they start to participate in the model. That global budget for each hospital is determined by utilizing a look back period of 1 to 3 years, whichever is best for the hospital. And then the model, essentially the model recaptures net patient revenue that may have likely decreased since that time. So that global budget is established with each one of the payers for that hospital. And then the second tenet of the model is the hospital is incentivized to reinvest in community health to retain revenue. And they do this by creating a transformation plan focused on 3 main goals that the hospital selects that is relevant to their community population and the things that they want to target in their community. So under fee-for-service, the hospital is paid for the number of healthcare resources consumed by the community, but as daily census decreases, so does revenue. If you look on the global budget side, hospital is paid the same amount of money as historic net patient revenue, regardless of how many resources are consumed by the community. So the hospital is essentially paid to keep people healthy. Fee-for-service revenue, you just see that a portion of this shows that patients are seen in the ED that could have been furnished in a primary care office, and also there's a certain amount of readmissions that these are the areas of potentially avoidable utilization. So by retaining revenue associated with the reduced PAU, the hospital can invest, as we said before. So what are the strategies for folks to reduce potentially avoidable utilization and admissions? So some of the goals that the hospitals have focused on are implementing or expanding care coordination, which includes focusing on chronic conditions such as congestive heart failure, COPD, diabetes. They also, some of them have implemented community paramedicine or mobile integrated healthcare programs. Another area is integrating primary care. So many of the hospitals have either increased the number of provider-based rural health clinics or just focused on making those more efficient. Social determinants of health is a big issue. Substance use disorder, they are really looking at anywhere that community has significant numbers of individuals that are coming to the emergency department that could potentially be avoided, or targeting the readmission, the hospital readmissions. So some of the other areas, mental health, oral health, telemedicine, and operational efficiencies. So Pennsylvania currently has 16 critical access hospitals. The hospitals that are in the green are participating in the model the first year. So 3 critical access hospitals participated out of 5, participated in the model in year 1. Year 2, we had 2 more that joined, and they are still recruiting for year 3. We just had a new hospital, Conemaugh Miners Medical Center. They just became a CAW in July. So some of the activities that we focused on for Flex that were related to the rural health model was a cost master initiative that was developed with Stroudwater to analyze costs in preparation for the rural health model. We also did a significant amount of CAW education and recruitment, where the rural health model team would present at our consortium meetings. We also, one of our the project that we selected for our Flex EMS supplemental utilized a regional EMS resource and capability assessment, and we were doing this to determine feasibility of implementing rural community paramedicine programs with the hope that we were going to apply and receive one of the Flex EMS grants, which we were not successful at getting. So we still have that on the back burner that when that comes up again, we'd like to apply for that. 2019 Flex funding, some of the Flex funding went to a team from Harvard that helped to develop quality metrics for hospital assessment for the model. Also, we put on last year a Rural Health Care Transformation Summit, which critical access hospitals, rural health clinic leadership, and some small rural hospitals came to, that primarily focused on value-based care. And then for 2019, we started with CAW transformation plan implementations, assisting the critical access hospitals on the plans that they have selected. Many of those activities were delayed due to COVID. So for 2020, our Flex funding is committed to another Rural Healthcare Transformation Summit, which was very successful last year, and more focus on CAW transformation plan implementation. So the progress is I said the summit was a very big success. We also have completed our portion of assisting with CAW recruitment. They are very educated on the model now. The Cost Master project is still in progress, and that has morphed over several years, but currently includes the four independent CAWs that are 3 of which are participating in the model. And I talked about the other 2 items. So challenges for the rural health model focused Flex projects. Unlike the Maryland model, participation in the Pennsylvania rural health model is voluntary. So recruitment in the first year was very challenging. There was tremendous interest, but many of the boards, the leadership of the hospital really wanted to move forward, but ultimately it was a decision that the boards had to make. And some of them wanted to take a wait and see Also, hospital transformation goals have changed, and so we have to really stay flexible with this. And then the number of CAUs participating in the rural health model, obviously because the flex funding supports critical access hospitals, we can't fund hospitals in the model that are not critical access hospitals. So we have to make sure that we are utilizing the funding for critical access hospitals. There was a slower startup for cohorts due to differences in hospital transformation goal selections, and COVID-19 obviously has been a big impact. So we think our successes have been that all CAUs are pursuing some aspects of the transition to value-based care, although not all of them are participating in the model. So when COVID hit, we found that the hospitals that are participating in the model had greater financial stability because they received their global payments even during the time that they were closed. So it wasn't based upon how many people they were seeing, it was based upon prior years' revenue streams. And CMMI did approve a year 4 of recruiting for the hospital. So it was originally supposed to only be 3 years of recruiting, but they did get an extra year because of COVID. Some of the other things, there was telemedicine significantly increased, development of working groups, and there has been a renewed focus on cohorts. Other considerations for utilizing Flex, we've just really focused on what do our hospitals want. If we can't generate interest, then the hospitals aren't interested in participating in those things. So we've really just listened to our hospitals and really tried to utilize surveys and lots of different feedback mechanisms. And if you want to learn more, I've provided Janice Walters information. She is the Chief Operating Officer for the Pennsylvania Rural Health Redesign Center, and she is the one that's primarily been recruiting and implementing the model across Pennsylvania for the hospitals. And then there is my information as well. Thank you. You ready, Stephanie?
I'm ready. All right. Getting this ready. Okay, can you guys see my slides?
Yes.
Great.
Okay, great. Thank you. So yes, hi guys, I'm Stephanie Saig. I'm the Idaho Flex and Ship Coordinator. And I am going to talk to you guys about Idaho's sort of transition to value-based care. It is definitely not a straight path. It continues to wind and progress as we go, depending on the day, but I'm going to share with you our experiences because I'm sure some of you have come across this as well. These are the primary objectives for the presentation that I'm giving you today, just basically identifying the needs for value-based care, our project's progress and impact, and then ways that other flex programs can step into value-based care. So just to kind of give you some background, Idaho was awarded Centers for Medicare and Medicaid Innovation, or CMMI, State Innovation Model, or SIM, 4-year grant, and that ended in January of 2019. So in February 2019, Idaho established the Healthcare Transformation Council of Idaho to continue Idaho's transformation efforts and movement towards value-based payment models. HTCI and its work groups received support from the Office of Healthcare Policy Initiatives, and that was recently put into the Bureau of Rural Health and Primary Care, where I work, in September. So that has allowed us to be more connected to the work that's being done in this area. Telehealth is one of the three. So we have Payer Provider Work Group, Telehealth, and then I'll talk mostly about the Rural and Frontier Healthcare Solutions Work Group. But for telehealth, that will be coming to a close in September. We are doing a final report. They've had a lot of work and a lot of subject matter experts. Idaho is pretty far behind the 8 ball when it came to telehealth, and it has grown exponentially during COVID and opened up a lot of opportunities. And they have been meeting consistently over the last year or so. So they'll be phasing out with their final report, and then we'll be looking at establishing a new committee focused on developing loan repayment opportunities for nursing and supporting rural nursing workforce efforts. So I'm going to dive into that third work group, which is the Rural and Frontier Healthcare Solutions. HTCI essentially recognized that although national focus on value-based healthcare strategies are predominantly addressed in urban and suburban markets, rural and frontier areas can also obviously benefit from transformational efforts. So in November, they established this small work group to develop an Idaho-specific value-based model for rural and frontier health systems. Essentially, this work group is working to develop, and this is a caveat, so this is how we started, right? We're working to develop an Idaho solution that focuses on improving rural community health and increase healthcare access through sustainable and using a value-based model. So participation is voluntary, but the group is actually committed to finding solutions to these complex problems that impact health and healthcare delivery in all rural Idaho. So ideally, the group was working to seek an opportunity to implement a model as a demonstration project. So just to kind of go a little bit more into the background of the group itself, as you all know, and I know I'm preaching to the choir, value-based models are pretty difficult for rural and frontier providers, hospitals, and clinics. Oftentimes, they have really limited financial resources to invest. They have a lack of interoperable data systems. They face challenges managing population health over these really large, sparsely populated geographical areas. And they often have burdens satisfying either performance measurement or reporting requirements. Idaho, like Pennsylvania, does not have an all claims database, which is also a challenge. So this work group really is a grassroots effort to kind of see what's out there, what can we take advantage of, and how can we sort of Idahoize it. Really what you'll see, the folks at the table are Idaho Critical Access Hospitals. We've got our hospital association actively participating. We have our Quality Improvement Network, Quality Improvement Organization at the table. We have a clinically integrated network represented. We have a university participating, and we have one insurance company. The rest of the insurance companies are aware of what we're doing, but they are not at the table at this point. They don't feel like we're far enough along. And then just so you know, as far as some of the convening, and I'll go into this a little bit more, but we used Flex funds to kind of get this off the ground by hiring a facilitator and a note taker, because there is a lot of dialogue that's happening very fast, and we wanted to be able to be actively present. And our bureau staff really oversee all of the logistics, literally like posting minutes, creating agendas, trying to coordinate meetings, identifying subject matter experts, trying to figure out what are the data needs to support the group, researching existing value-based models that are out there. It sort of runs the gamut. So just to kind of give you an idea of why in Idaho we felt like there was a need for value-based care, you know, much like probably most of your states, our rural health safety net is really based on critical access hospitals, rural health clinics, federally qualified health centers, pre-medical clinics, and of our 27 Idaho critical access hospitals, you know, we really rely on them to strengthen the rural economy, provide employment, and serve as sort of the healthcare hubs of their communities. They deliver a unique set of services, and although we have these really wide open geographic spaces that everybody in Idaho really loves for their active lifestyles, we have to make sure that that healthcare service delivery is still there. And we have a lot of significant healthcare workforce shortages, supply and equipment costs, limited resources when it comes to higher health service delivery. So that's probably not unique to what you guys also see in your states. In Idaho, we only have 6 of the 27 that have positive operating margins. And that was pre-COVID, right, during good economic times. Day-to-day operations are challenging, and they leave very few resources to efficiently and innovatively meet all of the current changing needs of the rural communities. the current reimbursement environment reduces the revenue for CAHs who choose to do the right thing and decrease unnecessary utilization services. The lack of opportunities to participate in value-based payment models that should actually financially reward them for appropriately reducing utilization waste and developing more efficient systems is really what brought us to the table. And we also had some really great opportunities to bring in folks from Maryland and Pennsylvania, and I'll talk about that a little bit here. So sort of the how and what behind what we started to do. So finding that path to stabilizing and transforming valuable healthcare resources is just as important as anything we could be doing for Idahoans. And with this work group, we really wanted to figure out an Idaho solution, and that's very important in Idaho. And so what we started to do was just convene, and we brought the CEOs and the CFO to the table, right? So everybody came in every month. And you would think that's not very hard because we didn't have a whole lot of people, but actually just the logistics for that alone of making sure that everybody could come to the same place at the same time consistently, and then in between that time finding subject matter experts and doing all of the background data research and everything else that people needed before the next meeting was a heavy lift. But we began convening in person. We went and compared and contrast the Maryland model, the Pennsylvania model, and the Vermont model. The individual that's the university representative was really great about trying to kind of break down the key concepts for us in a way that everybody could understand. We brought in subject matter experts to speak with the group. We had actually Jen Walters spoke to our group that Jen was able to allude to at the end. We had a former CMMI representative. We had somebody from our Idaho Health Data Exchange. So we've had folks come in, but we've also sought guidance from a slew of other folks, and it's just been remarkable about who has come to the table. I think Carla's on today, so Carla Wang was amazing. Terry Hill was phenomenal at getting us connected to the right resources and trying to figure out who to speak to. Clint McKinney was a great person to kind of get ideas from, especially starting off, because it sounds really good on paper, but when you're trying to figure this stuff out from scratch, it can be very, very complicated. So I'm going to talk a little bit more about just specifically the flex rule in all this, because it is very complex, and this is just one area. Although I will say that, you know, our office works really, really hard to not silo. And often, you know, like critical access hospitals, we wear multiple hats, but in some ways that's good because then you can always be at the table. When it first started out, Flex was really just a convener, right? Trying to have those initial conversations, sending the messages to CEOs to try and get them at the table to just even have a conversation. Some folks knew a little bit about value-based care, some didn't know anything at all, some were just intrigued but didn't, you know, were kind of hesitant. But also just having that supportive environment and the kind of working relationship where you can talk with folks and have an open and honest conversation, that's been really fundamental. So not only to convene, but to keep them engaged. Researching, right? Researching different models that are out there, different tools, different strategies, who's doing what, where. That's been important as far as Flex is concerned. And then funding support. So I mentioned, you know, trying to have a facilitator at the table so that we didn't have to be focused on that. Travel, getting a conference room back when we were meeting in person. Speaker fees, if anybody that was coming to present needed some funding in order to do it. And that sort of thing. And now we're doing everything virtual, which has its own challenges, but that's still the case. And then I would say just for me, it was the strategies of Flex, right? To partner and leverage existing relationships. You know, we looked internally, we looked within Idaho, we have connections to Medicaid, again, with the insurance companies, just trying to figure out who to get to come to either participate or stay at the table. But then also just the connection to national partners and organizations like the National Rural Health Resource Center and the QIOs and all those things. So I will say that one of the biggest pieces as the Flex coordinator is because you're out there doing site visits and because you are really working to make your program as effective as possible, those conversations really carry over, and using this as a platform to figure out how to make our Flex program as innovative as possible and how to support the needs of these folks as they try and take on this really challenging endeavor, I think is really important. So just being aware and listening and having that kind of relationship where they feel like it's a safe place to share not only dialogue, but information, data, that sort of thing. Challenges and opportunities. So as you guys probably are all very aware, that rural focused CMMI grant that we were all so hoping to get underway was delayed multiple times, and at this point I believe it's suspended indefinitely. I haven't heard anything differently, but we still continue to forge ahead. And if anything, it kind of gave us a little bit more time. I mean, we really hit the ground running fast because we knew that was coming, and it was great as a motivator. And since that sort of has died down a little bit, it gave us a little bit of breathing room, but then you kind of have that double-edged sword where you kind of lose a little bit of momentum. I would say COVID has been probably the biggest challenge because meeting in person is much, much different than meeting virtually. So trying to keep folks engaged and also CEO and CFO bandwidth to be able to participate in meetings. We've definitely cut down the amount of time that we spend in a meeting, which means that we are able to tackle sort of a smaller list of stuff. So all of our meetings are very, very, everybody has to be very streamlined. And then I think finding subject matter experts is always a challenge. I think finding the right individual to actually lead this initiative that's asking the right questions. I feel like we've kind of hit not necessarily a wall, but we're at a point now where we've looked at the models, we've seen what we like, what we don't like, but I think that there's still more to suss out from that. So I think that's always a challenge. And then accessing data. Everybody wants it, but they're not really sure what data they need or why they're asking when you ask the question, because you have to actually do the data request. We have a really good relationship with Medicaid, so that's been very helpful. And our QA and QIO has been very helpful for the Medicare data, because ultimately what we're trying to do is look at attributed lives. Right now, Medicaid in Idaho is looking to establish their own value care organization, and they only want to do it right now with urban hospitals. But the challenge with that is that they will, in fact, pull in primary care clinics, which indirectly impacts critical access hospitals. So with what we're looking at now, this is sort of a new caveat. This just came about sort of in the last couple of weeks. We are looking at attributed lives based on primary care clinics, and we're looking at how we can connect with Medicaid as they look to establish this value-based model. And it's an alternative payment model, but they don't want to do anything but one. So whether it's PPS or critical access hospital, they're just going to do one, but they don't actually have critical access hospitals at the table just yet. In Idaho, legislation required Medicaid to reduce their costs and change their reimbursement for inpatient services, which is why they're looking to do this right now. So we see this as an amazing opportunity. It will ultimately help to allow CAHs to potentially have a say in their destiny or future as it relates to Medicaid. And to be honest, we wouldn't even be at the table to be having the conversation with Medicaid if this whole HTCI initiative hadn't happened. So we find that as a unique opportunity. So where are we at now? Like I said, we're doing virtual meetings. We're collecting data. We've also got Compass data, and we've got the Idaho Hospital Association's cost reports. We're researching governance models, and all of the hospitals that are at the table are currently filling out the Rural Health Value-Based Care Assessment. If you guys haven't seen that, it's really helpful to kind of see where everybody's at. And then our university representative is looking at a way to kind of compare and contrast that, because there isn't a tool for that right now. And so we're collecting that data as we speak and trying to see if there's a way to kind of look at it as a group comprehensively to see where there may be some consistent gaps or needs. And we're currently looking for a subject matter expert or a consultant to kind of help push this group over that hump, to try and take on the next task and see what are the right questions to be asking, what should we be doing. And like I said, we're meeting with Medicaid to look at this new prospective payment system, sort of value-based model that they're creating, because that is one of the big reasons why CAHs that came to the table, they said that they were, if you're not at the table, then you're on the menu. That was specifically what one of the CAH CEOs said from Bear Lake Memorial Hospital. And it's stood true for every meeting. So having them have a say in their future is very, very important. So ways for flex programs to sort of step into value-based care. My suggestion is just learn what's out there and talk with other flex programs. And talking to different subject matter experts, it really helped to start with task and then reach out to rural health value. Being out there and talking with CEOs, ask them what they're thinking, what do they need. During COVID, it's so unstable and difficult to find bandwidth. So I feel like there's probably more need than ever to explore these opportunities, but we have to provide them in a way that doesn't make it so complicated that they want to be able to present it to their board, they want to get buy-in. So I think all of those things are really important. And then looking at your state cost report data, right? Just looking at any urgency or challenges that might motivate others to engage in the conversation. And then also working to determine alignment or opportunities with existing efforts. Like in our case right now, the Medicaid opportunity may end up becoming sort of the focus of the group instead of where we were before. This may trump it because it's an Idaho specific thing that's going to happen anyway. So if they can align themselves in a positive way, it may lead to other opportunities down the line. But again, like I said, our path is not straight and narrow. It's sort of windy and every turn is a little bit different. But if we weren't convening in the first place, we wouldn't even be at the table. So that's been really important for us. And that is all that I have to share today. I hope I didn't ramble too incredibly much. I'm going to stop sharing and hand it over to Caleb.
Cool. Thank you, guys. Thank you, Steph. Thank you, Jen, for both of your guys' presentations. We got a few questions in the chat box. Just a reminder, we've got a 10-minute break following this session, then we will go to a state-specific responses addressing the coronavirus, and then some breakout sessions from that. So there were a couple questions that came in. I want to make sure we get to those. The first one came in from Diane, and she was asking whether or not if it's been figured out how long that reassessment will take to do, Jen. If the population continues to decline and there's nothing happening in that hospital, how long can we expect those payments to remain unchanged?
Yeah, there is a reconciliation process, but I'm not as familiar with it as Lisa Davis is. So I'm going to let her answer this if she is unmuted.
There, Lisa.
She doesn't have a mute button, but we can't hear her.
Lisa, if you roll your cursor across the bottom of your screen, a menu bar will come up and you should have a mute icon in the lower left-hand corner of your screen.
It doesn't look like she has the mute button on. Well, if she can't answer, the bottom line is yes, there is a reconciliation process. It's not as, straight and narrow as you would think, but to get specific, Lisa might be connecting. She would have to answer that. I don't know any more than that. Sorry.
No worries. Thank you. And it's good information that, yes, there is a reconciliation. We're just not sure the details right now. And Marie Varziniak from New Hampshire, I believe. The Carla Wang posted the link down below to address your question about some of the activities, I believe.
Yes, and it's a really helpful assessment. I think it's highly recommended. And it was recommended to us from Pennsylvania, from Janice. That was one of the first steps she said to kind of take. So, and it's good information for a flex coordinator anyway, if you're looking at maybe even embarking on population health initiatives or different things like that. There's a lot of information that comes out of it, and they have to kind of meet as a team to talk through it. It's not something that's sort of a one and done. Like they need to have conversations about certain aspects of it.
Yeah, thank you very much.
Caleb, this is Carla.
Hey, Carla.
Answer the Marie question, because under the Rural Health Value hat, we've been facilitating the transformation planning for all the Pennsylvania hospitals.
Thanks, Carla.
Yep. I don't know that I can get into the how they reconcile the budget, other than it's very complicated and it happens regularly. But on the transformation plan pieces, it's actually each hospital has its own transformation plan. So there has been, so each of the 5 critical access hospitals that are now part of the model each have kind of their own activities, but there has been a fair amount of effort kind of across those hospitals that are participating to try to line them up and provide joint support and alignment, either from the Flex program or from other Pennsylvania kind of state resources and connections. So there's a lot of work across, but I do think that's a really important point about the Pennsylvania model that sometimes gets left out of some of these value-based pieces, is that to be part of the model, the hospitals actually had to spend a fair amount of time and thought into actually designing a transformation plan of how they were going to reduce potentially avoidable utilization, increase efficiency, and address the service needs in their community that would then align based under the model. So for example, they could do COPD rehab, which was really hard to do. Pulmonary rehab is really hard to do under a fee-for-service environment. This payment model gives them a better opportunity to do that. So some of them have done a fair amount of like opioid and substance abuse focus, behavioral health focus, a lot of work around care coordination in those plans as well. So that'll be my quick 2 cents on that.
Great, thank you very much, Carla. 1 second.
And then Caleb, I think there was a question from Stacy about how did I get cost report data for the hospitals? Can I go ahead and answer that?
Yeah, there are a bunch. So let's do 1 or 2 more just as time allows. I do want to make sure everyone gets a break and can use the restroom, and remind everyone that we are going to collect all of these questions in the chat box, answer them, and then send them out to everyone with the recording.
Yeah, so as far as the cost report data, the Hospital Association is one of the co-chairs, and so they were able to compile that information for us to be able to have the conversation. And for the most part, everybody at the table has been pretty transparent about data, so they've been able to share some of that information, whatever we need. But for the most part, the initial compare and contrast kind of stuff looking at cost report data came from the Hospital Association.
Awesome, great, thank you very much. So yeah, just a reminder, thank you everyone for typing your questions into the chat box. We'll take a short break here, and there is a link to the next session in the bottom of the chat box there for you. So thank you again, Jen and Stephanie, for your discussion about the transition to value and your guys' efforts. It's been great to hear about that as you guys participated in that collaborative. It's been nice to see how those things are going and your guys' efforts. So we will see everyone back at 1:20 for a coronavirus state-specific responses discussion, and then a facilitated discussion following Tracy's intro, the link for which is in the chat box here. Thanks, guys.
I just want to add one more thing, Caleb. If you misplaced the link or don't click on it in time, if you go back to the home page of the portal, on the top there will be a button that says Watch Live. Click on that, and that will also bring you to the coronavirus small group discussion.
Cool. Thank you.
Thanks, everyone.
Thank you.